Okay, welcome. So I'm now not in the convention center, but in the Westin here in the North River, and you see Chicago in the background. And what we're going to do is go through some studies that struck us both. Now, with me is my friend Dr. Campos, and I'm going to have her introduce herself. But we both do gynecologic cancers or pelvic malignancies. And my friend Jasmine joined from American Cancer Society, which is great. And so we'll do that. But after I asked Dr. Campos about her studies, I'll also update you with stuff that went on during what's called the plenary session, which is when the most impactful studies are also presented. So first I'm turning over my little mic to Dr. Campos to introduce herself.
Hi there, welcome from Chicago. I'm Sue Campos. I'm a medical oncologist at the Dana-Farber Cancer Institute, and Don and I have only known each other for about 101 years. Yes.
And we haven't aged at all.
No, none at all, absolutely none. None. Younger every year.
Every year. So, Sue, the gynecologic cancer abstracts went on the last couple of days, and
yes.
We had what's called the oral abstract session yesterday. So tell us the major studies that struck you.
You know, I think what was actually very interesting is to actually just to kind of have reviewed the Ruby 1 trial again and the impact that it's actually going to make in our patient population with uterine cancer, especially the deficient MMR. I think Matt Powell did a wonderful job in really assessing, again, reviewing the trial of Ruby 1, but talking about some of the endpoints. And I think one of the most striking things was Jenny Fleming, who actually gave a wonderful distillation in terms of some of the trials, including the Ruby 1, but also the patient-reported outcomes, which suggested no actual negative outcome from actually being on the dostarlimab. So it just kind of validated again what actually was said at SGO.
Right. So just for the audience who may not know what the Ruby trial was, just who was the population, what was the randomization?
Absolutely. So, the Ruby 1 trial actually was in stage 3, stage 4 recurrent uterine cancer, and patients were randomized to either carboplatin Taxol and placebo, or carboplatin Taxol and dostarlimab and maintenance therapy. And it was pretty striking, that the progression-free survival was quite significant for the deficient MMR and in the intent to treat population. The key, actually, in the Ruby trial is that there's an overall survival endpoint. And right now it's immature, but it's leaning towards an overall survival benefit, but again, immature. But really did show a tremendous benefit in terms of the deficient MMR. How we're going to interpret this in terms of the group as a whole, this is applied to the proficient, or is it something in the proficient cohort that we've yet to learn, remains undetermined. But at this point in time, very striking.
So let me ask you a question. So we talk about MMR deficient, proficient, just for the audience. This is a characteristic of the tumor that has proteins that do not, that are supposed to help the host repair damage to its DNA by mismatch. And if you're deficient in those proteins, there's an increased risk of cancer. If you are able to get dostarlimab for people who do not have this deficiency, who do not lack mismatch repair protein loss, would you use dostarlimab? So in the MMR proficient population.
At this point in time, I would, because the study is actually really leaning in that fashion. It's not only the Ruby 1 trial, you got the NRG-018 that, again, actually, analyzed the proficient separately and showed a progression-free survival benefit. But I do think we all have to think, in time, will these curves hold up? And I'm not talking about the deficient, the proficient. Questions that I think are circulating now is in the proficient group, how many of those patients had a high mutational burden? How many of those patients were POL1? Would that have changed the hazard ratio? And, we'll know in time. These studies are actually quite immature. The NRG-018 is, was a median follow-up about 7 months. Very short.
Yeah.
And the Ruby, perhaps longer, clearly. But again, these are certain questions that I think we're going to have to decipher, because it's going to be incredibly important in terms of what we do when and if patients do relapse. Do you reinstitute immunotherapy again, having had immunotherapy earlier? So these questions have a domino effect. A domino effect.
Yeah, and I think that's for the audience, who, for those of us who treat uterine cancer, we had this whole host of data that established immunotherapy in uterine cancer, but only for people who had not seen it before.
Right.
And now with Ruby, we're moving it all up. And so the question is, did we just blow up all this data?
Or are we going to get smarter and think to ourselves, perhaps if patients do relapse and they've had IO therapy, it's combinations of pembrolizumab.
Yeah.
Are there other contenders like bispecific combinations that can be important? But, we need to be thinking about this if we haven't thought about this before.
And I think we need to be probably more intentional about it. It does raise a lot of questions.
Absolutely. Yeah, good questions.
Good questions.
Absolutely good questions, yeah.
You know what? I forgot to mention, but I should disclose that I was on the Data Safety Monitoring Committee for the Ruby trial, although I think the data that Susana and I just were commenting on are data that was already published and presented. So that's the only thing. What else struck you?
So, I think that the Mirasol trial is a very interesting trial.
Yeah.
I think so. Granted, it solidified what we knew from the Soraya trial, platinum-resistant ovarian cancer, the use of an ADC, mirvetuximab. In the Mirasol, it was up against, physician's choice, which was paclitaxel, Doxil, topotecan. But to really have a striking progression-free survival and an overall survival in platinum-resistant ovarian cancer is monumental, and we haven't seen that as long as I can remember, to be honest with you. And, it's a new drug. It comes with a new set of toxicities that we all have to kind of align ourselves with, namely the ocular toxicities. But, we've been using this because we, with the Soraya trial, and, the ocular toxicities require, it's a bit more work in terms of preventing them, but they're not obstructive, I think, by any means, I think that what you have to be careful with is the adjusted body weight, and you have to be careful because it's a different dosing, and so I think that's something that we're not used to. But I think the Mirasol data was actually very, very striking. I think so. Yeah,
it was. Yeah. And then again, the drug is called mirvetuximab.
Yes.
And in terms of the eye toxicities, they're not some things that we're used to seeing. It's not like inflammation of the eye. This can cause retinal cysts, microcysts in the eye that can cause blurry vision. Fortunately, if you stop the drug, that does resolve, but it does lend an issue in terms of how to follow these folks.
Yes.
We don't have ophthalmologists in cancer centers.
Yes.
So how are you guys managing the ophthalmic follow-up?
Strictly, so patients are educated in terms of what the ocular toxicities can be. They're really educated in terms of how to go about and mitigate some of this with the eye drops. So very regiment. And I'll tell you, people have been really great. We have reached out to, our optometrists as well as, ophthalmologists as well as optometrists, and actually they've been incredibly gratifying in terms of how they responded. I've had patients who've called ProVision and they were in the next day. I'll tell you very honestly, so you send them to slip and it gets done, and so it is completely doable, especially when you're starting to see these type of responses in platinum-resistant ovarian cancer. It's pretty cool.
Well, okay, so the thing that happens with the testing for eligibility for mirvetuximab, the testing requires evaluation of the primary tumor. If someone was diagnosed with ovarian cancer, say, 2 years ago, we send that tumor for testing because the theory or the understanding is that the biomarker, which is called the folate receptor alpha, does not change. It's not driven by tumor progression. But we had a case.
Yes, we did, as we did also. Yes,
where you send the recurrent specimen, and it's elevated. So what is your advice to people about testing for folate receptor alpha?
It's very interesting because we had a similar. Well, I think we had it wasn't our case. No.
It
was somebody else.
I did not send it to the Farber. This person was not sent to the Farber.
No, but I think we had one of your colleagues who actually had the original biopsy, the original archive tissue was folate receptor alpha negative, and yet the more current fresh biopsy was positive. So again, what does it say? It speaks to what we know all along, the heterogeneity of tumors. So I think that we went with the one that was positive, and she got ahead and she got treated with that. So, but it's quite interesting. I think it speaks to the heterogeneity of tumors.
Yeah, So if you test negative in the primary tumor, would you suggest we test the
Absolutely.
You do?
Absolutely.
Okay.
Absolutely. And in essence,
you heard it here first on TikTok by Dr. Campos.
No, you really should. This is a huge advantage to patients, something that we're not able to give. The data speaks for itself. Yeah. It's well done. It
is. Okay, so I agree with mirvetuximab. I think it doesn't open a new line of therapy because we've been using this drug, but it certainly clarifies, and I think for me, certainly, it solidifies that you should be using this drug if people have this overexpression of folate receptor as your preferred treatment. Yes?
Agreed. Yeah, absolutely. Yeah.
Okay, what else?
I think the duo data was interesting, but the question is how how to swallow this data. I think, once again, and this particular data is looking at, carboplatin and Taxol, durvalumab, with durvalumab as a maintenance therapy, and then chemotherapy, the carboplatin, Taxol, durvalumab, and Bev, followed by, I can't remember Bev, okay, followed then by Bev, durvalumab, and olaparib, okay?
Yeah.
And
so again, it's 3 drugs versus 4 drugs versus 5 drugs.
Seriously, yes.
Yeah,
yes,
so just
yes,
to be clear.
yes.
And I'm going to do another disclosure. I'm on the Data Safety Monitoring Committee for DUO. So Sue is going to talk about most.
And so the data as was presented was, they really compared arm 3 to arm 1. And there was a progression-free survival benefit. But I think what's come to light once again is what is the magnitude of benefit of each of these drugs. And we don't have a olaparib arm only.
Yeah.
And again, at the end of the day, does this really recapitulate the Paola data where we didn't have that single arm data, and so we don't know where to make for this?
Yeah.
Now, keep in mind, this is in non-germline mutation carriers, so I think that's extremely important to tell. They had a small cohort, I think, of 190 patients that they did not analyze data or present the data. But I think, I think it leads us to ask the question: what is the magnitude of benefit of not only the Bev, the Durva, and the olaparib? What would it have been like if, in essence, you just had a single-arm olaparib arm? I mean, what do you think?
Well, so again, I have to be careful. I'm going to stick with the data, and it's sunny, so I'm putting my sunglasses on and taking off the hot pink eyeglasses that I've been wearing the last 3 days.
Which are fabulous.
Are they good?
Yes.
They're good, right? Okay. So I think you're correct. We know that this drug, it's a PARP inhibitor. It's called olaparib. Has tremendous use. And its original approval was the treatment for people who have a mutation in BRCA, which this drug specifically targets that. But we now know it also works in people who don't have that mutation, which Sue was talking about, but they might have other signs it might work, called homologous recombination deficiency. But so the question is, what did durvalumab do on top of that? Can we prove that? And I don't think we can.
And I think it's going to be very hard, not at first blush. You know what I mean? In terms of the data that was presented, I think it's going to take a little bit more of scrutiny of the data to see what the magnitude of benefit may be. But again, you got to think to ourselves, when were these studies actually initiated? They were initiated before we had a lot more data, so we're kind of looking back and thinking we probably would have designed the trial a little bit differently today to try to address the question. But regardless, it was a positive data, and I think we have to say that indeed it was. But again, I think it requires a little bit more scrutiny at this point in time.
Yeah, I think you're right. It's interesting when you look at immunotherapy for ovarian cancer. We've tried.
Yes.
And the studies have not shown that immunotherapy drives better outcomes. So this is actually the first study that shows immunotherapy might drive a better outcome. Right. But you're talking about using 5 drugs, and I think probably the bar should be higher if you're going to do that.
Exactly. And what is there going to be any analysis between arm 2 and 3?
Well, yeah. So we'll have to see. Thank you, Jack's mom, for saying this is the best live you've ever seen. We're trying. I think the view's nice. It's very, very sunny here. Sue can put on her sunglasses.
I can.
Like.
It's okay. I'm good now. Thank you very much. Yeah.
All right. So what else?
That really kind of summed up, I think, at this point in time, what was actually presented. I think was going to be interested in looking at some of the data on the trastuzumab D in other than breast cancer that's coming up. I think that's going to actually be quite interesting. But I mean, I think these abstracts, I think just solidifying and the Ruby 1 data, I think was actually very powerful. The Mirasol data, was one abstract that I think is actually incredibly interesting, and it talks about constitutional hypermethylation.
Oh, interesting.
It's very cool because oftentimes in our
you want to just define.
It's basically, interestingly, is individuals that are you deficient in MMR, you test and they come up hypermethylated. However, they may indeed it's more than just having a sporadic. It's not really more than having a sporadic mutation. These are patients who probably can get endometrial cancer, colorectal cancer under 50. So there is an abstract out there that really actually talks about perhaps we should be diving even a little bit deeper into those that are hypermethylated. We kind of say, they're hypermethylated, all good, we don't have to worry about them. But in essence, that may not be the case because they may have a constitutional hypermethylation, which in that case, you really do want to send them to genetic counseling. So look for that abstract. It's actually quite interesting, yeah.
So someone had a question earlier about what are your recommendations for people who do have a BRCA2 mutation? So maybe it might be a good opportunity.
A BRCA2 mutation? BRCA2, no different. No, basically, the patients, for example, if there's upfront therapy, they will then get treated with a PARP inhibitor. If it was a recurrent platinum-sensitive recurrent ovarian cancer, BRCA2, we treat them again, after chemotherapy with a PARP inhibitor. The question is, do you do PARP after PARP? And at this point in time, it really depends on disease-free interval.
Yeah.
I'm not really wedded to it at this point in time. But the important thing is also the education of the patient, the patient's family, making sure they meet with genetic counseling just to understand, not only their ovarian cancer risk, but their breast cancer risk and the like.
And I think that's true. I mean, one of the more frustrating things I see, and this is sort of stepping outside of ASCO real quick, is you have someone in your practice who has that BRCA mutation, and then maybe it's 6 months, maybe it's a year later, you're seeing their cousin, who also is now coming in with cancer associated with BRCA, and they know that their cousin had it, but they didn't know that their cousin had a mutation.
Yeah.
We're missing this whole downstream protective mechanism by which we're testing everyone in families for BRCA, because if we were able to prevent cancer, then we should be doing that. But our obligation is to the patient we're treating, not to their families. Right. And that's what I think makes it difficult.
And it goes even like I had a wonderful discussion this morning about, education for primary care physicians. Oftentimes we see the patient that has the cancer, but in essence, the primary care physician also, educating primary care providers in terms of familial predisposition, because they may be the first person to actually see this and talk to patients about this, and allow them to kind of feel free to
start the conversation.
Yeah, absolutely. So it's not only in the oncology arena, but maybe even the primary care, really recognizing that, hey, this family has a significant family history of multiple cancers, whether it be BRCA, Lynch, what have you. Yeah.
So there's one other study that we didn't talk about, and it was the overall survival results when we use immunotherapy in cervical cancer.
Yes.
Did you see that?
I did.
What are your thoughts on that?
I mean, I think it's striking. I mean, this was the Keynote 826 study.
Correct.
And basically, it showed the benefit of Bev and Pembro plus chemotherapy in patients with cervical cancer. I think it really is one of those studies that have changed the way we treat patients with advanced cervical cancer. I think it's excellent, to be honest with you. Yeah.
It was. I mean, just, again, it's where immunotherapy proved its role for ovarian cancer, or for cervical cancer, this place.
Yeah.
But using immunotherapy in people who had a biomarker for its use, and this was called the combined positivity score for PD-L1 testing. But if you had that biomarker, the use of immunotherapy extended overall survival by a year.
It's unbelievable. And the distillation that was given on the use of radiation and immunotherapy was excellent in terms of, if you have Keynote 826 showing a survival advantage, how do you bring this forward into the earlier management of cervical cancer? Some of the studies, they're clearly different. The Calais study was negative, but, the 18 study has yet to be resulted. And the question is, can you actually bring immunotherapy in the appropriate patient population earlier on, so that you make a significant difference earlier?
So it was not quite a savage who had asked that question about BRCA2. She doesn't have cancer yet. She's asking about, are there any certain tests she should do, or what is your advice?
Oh, I see.
Follow-up?
Oh, okay. I think that, before anyone goes out and gets tested for genes, you know what I mean? I think they should talk to their primary care physician, understand what the familial predisposition may be, okay? And what the ramifications are of testing for it, So most people test if they have a family member, that they know that a family member is positive or not. But just educating what the likelihood of that chance of being BRCA2, and really taking a good family history, I think is actually quite important.
And I think for anyone who's tested BRCA and doesn't have cancer yet, the decisions on what to do about it are not easy.
No.
And I don't think Sue or I would ever say it, but you're talking about prophylactic surgeries.
Yeah.
So I never recommend we do that in someone who's, say, 20.
No.
But if someone has completed their childbearing, have fulfilled their family wishes, it may be an opportunity to take out one's ovaries, for example.
Yeah, and this really comes down with a lot of counseling, and it comes down with, meeting with the genetic counselor, meeting with the surgeon, understanding the ramifications of any choice that is actually made, or the ramifications of not doing something also. Yeah.
Right. What else should we talk about from ASCO?
It's pretty much, I think it's a wait and watch game at this point in time. We've had these amazing studies that have to mature, and we're going to get smarter along the way, aren't we?
I think so.
I hope so, yeah.
So what are you seeing in the horizon in terms of, so we are Sue more than me, but both of us do a lot of new drug testing. Are you seeing any that you particularly feel may be promising?
I think that at this point in time, it's really the ADCs that are actually growing in popularity. I think trastuzumab D is an amazing drug, and I just can't wait to see what it actually may do in diseases other than that of breast cancer, like, for example, carcinosarcoma and the like. So I think those are the interesting drugs. I think we have some very interesting drugs on board. The question is how to use them appropriately and who to use them with, and start thinking how to strategize what we have. I mean, the deck is moving, and it's moving so incredibly quickly. The question is, how do we make sense of what we have,
Right. And, it's interesting, doing a TikTok live, you feel like you've been talking for a very long time, so we're rushing all of this, but we've only been on for 20 minutes. We're supposed to be on for 20 more minutes. But what are ADCs? Jack Small wants to know.
Sure, they're antibody-drug conjugates. So think about it, it's like a homing device. Basically it is a chemotherapy, but it's an antibody that targets, for example, a specific site on the tumor, like the folate receptor alpha. So think of it as a homing device.
Yeah. So Jasmine wants to know, how did you navigate this big meeting? I'll be honest if you be honest.
I've learned over the years, because I'm super old, that I select out what I really want to hear, because I think, a lot of the meeting it will be duplicative in time. I mean, you'll go to conferences, you'll talk about it over and over again. So, I'm particularly interested in the GYN, obviously, and so I decided to just hone in on those specifically, because, it's grown, on orders of magnitude. So you really want to just hear what you need to hear, what might help your practice, and then spend some time actually talking to your colleagues and how to distill some of that information. That's probably the most fun part. ASCO has a virtual capacity, which is amazing, and so anything that you might miss, you can always go back and look at a more relaxed time. Yeah,
and I think for those of you who don't know, this meeting is 40,000 oncologists strong. And the conference center is 4 football fields?
Yes.
And you can literally walk the entire way 8 times. Now, before the pandemic, if you wanted to enjoy ASCO, you had to come to the meeting. There was no virtual. But since the pandemic, there are these virtual options. So, I can actually not be in a room with 1,000 other people and watch it now virtually, from wherever I am, like a bar in the daytime with a friend on a TikTok live, and I can have that screen going. So it's actually made it much more navigatable. I think you have to be realistic about what you can do.
Yeah, absolutely. It's overwhelming otherwise,
It's 100% overwhelming otherwise.
And, I think that also, we have the luxury of coming to this meeting, and so, there are many practitioners who don't have that luxury, who can't take time away from their clinical practice, and so the option of a virtual option is unbelievable, because you can sit at home and you can watch it. There's no downside. You're looking at the slides, you're looking at the questions as they're presented, you're looking at the distillations, and then there are many programs that actually come afterwards in terms of a review of GYN, GI. So there are many ways to actually pick up on what you think you might have missed.
Right. But it's interesting. Sue and I always get together in Chicago, because even though I'm in Rhode Island and she's in Boston, I've only seen her in Chicago in the past year.
This is really sad. This is really sad.
This is despite our best intentions.
Yes.
All right, so going back, we covered much of the GYN oncology stuff. That actually caught my eye. Were there any other topics that you found interesting at ASCO?
I think those were the major ones. That's the major ones. How about yourself?
Well, so, it's interesting. Someone had asked about pancreas cancer, and I had Mark Lewis on for my TikTok live yesterday. There was a really interesting study for pancreas cancers that was presented by the Nordic group. And what they did, they took people who had resectable disease. So they could have gone straight to the operating room. And the question was, should we give them neoadjuvant chemotherapy first? Hold on, someone is invited. So the question was, should we give them neoadjuvant chemotherapy first? So they randomly assigned people to go to get chemo or to go right to the operating room. And the surprising thing to the community of GI doctors who treat pancreas cancer was that there was no survival advantage with the use of neoadjuvant chemotherapy, which in our I mean, we use neoadjuvant chemotherapy in ovarian cancer all the time. There's never been a negative result from neoadjuvant chemotherapy for ovary. We use it in breast all the time.
Yeah.
So I think this was very surprising, that, front-loading someone with chemotherapy before surgery made it difficult. But Dr. Lewis made the point that the surgery for pancreas isn't like it is for breast. It's what's called a Whipple procedure, and that's an exceptionally morbid procedure. And the question was, were people even capable of getting chemotherapy after surgery if you'd given them chemotherapy up front? Right. So there are a lot of things that you need to digest, but according to Dr. Lewis, it did not change his mind regarding the use of systemic chemotherapy, because people with pancreas cancer, they don't die from the disease in the pancreas. They die from the disease that spreads after that.
Yeah, no, it's interesting. Different biology. Completely
it is.
Different biology, yeah.
Yeah. Beyond that, I think today was plenary.
Yeah.
There was a study that looked at the uses of combined modality treatments in rectal cancer versus just chemotherapy. And again, it was a sense that if you do more, people may do better. And this study was one of the only ones to really test that theory. And it turns out there's no benefit to double treating with radiation and chemotherapy for rectal cancer.
That's interesting, yeah.
Yeah, and again, it's sort of, this debate's going on.
Yeah.
So looping this back in, and maybe we can just do a few minutes on this, is in the era where we're using immunotherapy to treat uterine cancers, what is your stance on combined modality treatments?
Well, it's interesting because if you look at the actual, if you look at our NRG01A data and ask the question of chemotherapy, carboplatin and Taxol, plus pembrolizumab, which was the winner in NRG01A clearly, in both deficient MMR and proficient, the question is, do you need the chemotherapy? Do you really actually? And I'm talking specifically. That's
the radiation or the chemotherapy.
The chemotherapy, because if you look at NRG01A, right, and I'm specifically talking about deficient MMR, those curves are pretty superimposable on each other until they go off and they just get in NRG the pembrolizumab. So it really kind of raises the question, can we de-escalate therapy for
fascinating.
So you got the C93 study that's going on, right, and that's going to be looking at pembro versus chemotherapy in certain select patients. So, my question is less more, and it very well may be in time. We're not ready for that yet, but specifically in deficient MMR patients, whether or not perhaps these are individuals who really that you could treat with pembrolizumab and actually get rid of chemotherapy. Again, premature hypothesis, but it is a possibility.
Mm-hmm. Well, so okay, that's fine. But what about the radiation part
Difficult part. That's difficult. That's very, very difficult. I don't know really what to do with that, to be honest with you, because you got PORTEC 3, you have, PORTEC 3, you got GOG 249, and so the issue of radiation therapy is a little bit all over the map. Mm-hmm. And yet we know patients actually relapse locally, so which is not insignificant.
Right.
There are many thoughts in terms of you could just salvage them with radiation therapy, but sometimes a local recurrence can be far worse than a distant recurrence. So I think the jury is still out on that.
Yeah.
You know what I mean? Are we going to all go to, vaginal brachytherapy and not give pelvic radiation therapy? That's a different by histology. You know what I mean? Like an endometrioid grade 1 and grade 2, where you think there might be a little bit more, but we don't have that information. Or will pembrolizumab or any IO simply abrogate the need for all?
Yeah, I hadn't actually thought about de-escalation, but I think that's a really good one. Farmer Girl had a question about low-grade serous ovary.
Yes.
What is your take on the use of chemotherapy for low-grade serous?
Which is an excellent question. You know what I mean? As we know, chemotherapy, the activity of chemotherapy in a low-grade serous is not as robust, as it is in high-grade serous. And, there is the 19 study that is actually looking at chemotherapy versus that of letrozole, which is a great study for low-grade serous,
which is a pill, it's an anti-estrogen.
It's an aromatase inhibitor, thank you. And it really asks the question, can you get away with not giving chemotherapy in patients with low-grade serous? I think the interesting with low-grade serous is, looking at the different genomic permutations of these type of cancers and, looking at different drugs like, MEK inhibitors. For example, at the SGO, we heard about ribociclib and I think it was letrozole, right?
Yeah.
Looking at a different way to actually target the low-grade serous. But, we're reminded of. And clinically, we knew this many years ago, that they were indeed different cancers, so they behave clinically different, but we really didn't have the genomic aberrations to really, kind of nail that down.
Right.
So chemotherapy, do we give it? Yes, we do. We do. But are we excited about it? No.
Yeah, so, I mean, I think the question is, when do you use it? When do you use chemotherapy in low-grade serous?
I think when I have a patient that has a stage 3 low-grade serous, I still go to chemotherapy, followed then by a hormonal manipulation, So, but like if I had a patient, with a stage 1C, 2, and, she had a lot of other comorbid conditions, including a secondary diagnosis of multiple myeloma, we did not go to chemotherapy. We went to hormonal manipulation, and with a lot of discussion, understanding that data has not emerged. But, I mean, if one has the option, I would enroll them on the study to try to answer that question once and for all.
So we're reaching happy hour, so the volume is going up, so hopefully you can still hear us. And I'm just going to let Dr. Campos know that Turning Tides wants you to have a TikTok, so you should open your own TikTok.
Oh, you're kind. Thank you so very much.
They want to know what your socials are, so they can hear more
absolutely.
from you.
I'm gonna do a little bit of a synopsis on that.
So and maybe at the end of this, while we're running out, we will do a dance.
We will not.
All right. So, I mean, in terms of coming to ASCO, then let's just veer off. What do you do outside of Crawford Center? Do you avail yourself of Chicago?
Do I play in Chicago?
Yes.
Yes, I do. Yes, I love to play in Chicago. Chicago is an amazing city. You got theater. I used to love going to the Goodman Theater. Of course, they're not playing anything at this point in time. That's right down the street. I have the fun of coming to ASCO. Obviously, the conferences, we come for that, but it's really for the, you see your colleagues, you talk to them about things that are going on with work, all the things that are good, all the things that are bad. You share some data, you catch up when you haven't had a chance because everybody's busy. But I mean, it's just an amazing city. So there's just so much to do, whether it be shopping, museums, the Art Institute, Goodman Theater, which is not open. But can you please be open during? Of course. But I did not go to the Taylor Swift concert.
We did not. Neither did I. I wasn't going to spend $1,000 on the ticket.
But if Taylor Swift wanted to bring us to the concert, we'd be very happy.
Yeah. So if Taylor Swift is seeing this, she should call us, and we're happy to come. So actually, a question was earlier raised about natural treatments for cancer.
So, be cautious. You know what I mean? The same scrutiny, I always tell patients, the same scrutiny that you use for anything in terms of what we prescribe, chemical, is the same scrutiny that you should use for natural. And I don't want to discourage anyone from looking at complementary therapies in conjunction with the systemic therapies that, are proven. But, look at them with just a cautious eye as you do with anything else, Right. I think that's actually quite important.
Yeah, and I think I usually tell folks that I don't have any biases against natural therapies. My big thing is, it should not be expensive so as to put you in debt. B, you should try it in moderation first so that you don't run into toxicities. And C, really important, tell us if you're taking something.
Yeah, absolutely, yeah.
But, what's also often lost in this whole idea of natural therapies is the fact that some of our treatments came from natural therapies. So Taxol, common drug, it was from the Pacific yew tree.
Adriamycin, the Adriatic sea, Adriatic sea, I mean...
Even the sea sponge has given us therapy. So a lot of these drugs, carboplatin not so much because that's a platinum salt. It was like a magnetic fields, blah, blah, blah. But, okay, so a relevant question then for the audience, because there's been a lot of talk here about ASCO, is we have a drug shortage.
Indeed.
Of chemotherapy that is very, very commonly used. What is the FARBR's response to that?
So, I think it's, there have been task forces that have looked at, who are the patients getting carboplatin? Is this individuals that are in the upfront therapy, the secondary therapy? How do we look at dosages of drugs when we give dosages at a level of 6? We call it an AUC of 6. What's the data that supports that you can give a 5 and have equal results? So we've looked at all of that. We've made transitions from carboplatin to cisplatin, so that we have just as more to give. And of course, looking at other regimens out there that may be helpful also during this shortage time, which I hope will be very, very truncated.
Yeah, we're hoping, and I agree with someone just said it's very, very scary. Everyone is really trying to do what they can to adopt it. I think the FDA is allowing us to ship cisplatin from international sources, which is good. But, I think we need to conserve. and stretch it out, and it's not an easy place for any of us to sort of be.
And my biggest concern is the emotional well-being of a patient, and when you have to describe this to a patient of what you have to navigate, that is my biggest concern and my biggest fear. I have to be honest. We'll walk around dosages, we'll switch from carbo to cisplatin, but just giving that patient that confidence of knowing that they're still being treated and they're being treated well is by far the most important thing.
Yeah. All right, so we have like 5 more minutes. If Eleonora Teplinsky is on, and I'm not sure if she's trying to go live or not. But Eleonora, if you're listening, congratulations. She was awarded the Social Media Influencer of the Year.
Great.
Congratulations. Sue is up for that award next year. And Sue, someone wanted to know where you're practicing.
So I'm practicing at the Dana-Farber Cancer Institute in Boston, Mass.
All right, and the last question, and then we can spread this out. Who are you wearing?
Oh, it's Madame Bloomingdale's, actually. Yes. And yourself?
And the pin? No.
The pin, actually, I don't really know where I picked this up. I was on the pin craze many years ago. So, I'd go to these antique markets and I would just find them. So, and you?
So I picked this up in Provincetown. It is knit. I think Jasmine Hargrave, who works with me at American Cancer Society, was very suspicious of my wearing any knits that had openings in it. I was not going to show much in the way of skin, as you can see, but I picked this up in Provincetown, and the jeans I got online.
There you go. See?
Because where I live is not near a big city.
That's okay.
Yeah, that's Sue. Okay, closing thoughts then for the. How do you ASCO? How about that? How do you ASCO?
How do I ASCO? I think number one, you take a deep breath and you navigate. You go to the conference. You talk to colleagues. You spend time really conversing about the data with your colleagues. Anybody can read, you can go online, you can see the presentation, but it's the dialogue that you have with people, the picking it apart, whether good, whether bad, and learning what other people are thinking, taking it home and interjecting is actually the fun part, to be honest. And then you have a little fun on the side.
Yes. Yeah. All right, and we are going to, like we said, I haven't seen Sue Campos live in about a year, so we're going to take advantage of this time and we're going to end this. But before we do, just know my last live at ASCO will be tomorrow during the GYN Oncology poster session. I'm not sure how that's going to work. If I'm going to do a rove with TikTok Live going and like accost people while they're trying to present their posters, or if I'll just pull people aside and have people join me. But Dr. Campos, amazing human being, a specialist in her area, globally known, and her very first TikTok. Congratulations. All right, thank you so much, everybody, for joining. And have a good, is it Sunday or Monday?
It's Sunday.
Have a good Sunday. All right, thanks. Bye. How do you close this? I think I'm done. 37 minutes. Good. Yeah. Okay. End.